Thanks, Jenna, and I think we're live.
Great.
Welcome, everyone, to our National Primary Care Week webinar with the AAFP President-elect, Dr. Robert Wergin. We're very excited to have him joining us today, so thank you so much.
Thank you.
Absolutely. So Dr. Wergin is a family physician out in Milford, Nebraska, who is currently the president-elect of the AAFP, soon to take over in his new and exciting role as president.
Yeah.
He's been a member of the AAFP Board of Directors, and for those who didn't know, the AAFP is actually an organization that represents 115,900 physicians and medical students nationwide. And if you didn't already know, the AAFP has free membership for all students and is a great place for opportunities for those of us interested in primary care.
True.
Take it away, Dr. Wergin.
Okay, well, I guess I'll start. And as a thank you, Jenna, for allowing me to participate, and I thank all the viewers. It's a great opportunity for our academy and me personally. And talking about rural primary care, you're going to see a little bit of my passion bubble through here. And I see some biases in some of the data I'm going to present. But to give you my background, it's true, as Jenna said, in just 2 short weeks, I'll be installed as president of the American Academy of Family Physicians, and as she said, over 115,000 members. And the big thing that I'm really proud of is there's 27,000 student members of the Academy at this point in time. 1 in every 4 med students in the U.S. are a student member of our Academy, and I think that's important. So you're exposed to it at an early time, and whether you go into family medicine or not, we don't really care, but we're very proud of that. It didn't happen by accident. We have a big focus on students and education. So just to preempt or tell you what my talk is going to be like today, I'm going to start off with just some raw data on rural practice, the need for rural primary care across our country. I'm going to touch on some issues related to rural practice, such as scope of practice, community involvement, and I'm going to probably reveal my bias, some of the advantages to being in rural practice in whatever state you're in. And and then at the end, what I want to do is, I'll tell you how I did this. I call it a day in the life. And what I did is about 2 weeks ago, I wrote down all the patients I saw in the morning of one day. And I'm just going to go over what my day is like, or at least that morning was from about 2 weeks ago, so you get a feel for what types of patients and who you see in rural practice. So I'm going to have Ashley advance my slide. Ashley, can you go to the next slide? So this next series of slides are going to talk about the need for rural physicians. And these maps that you see on the slide, the left side map, the red areas are physician shortage areas in our primary care rural shortage areas. The map on the right shows what the rural shortage areas would be if you remove family physicians. So you can already get a feel that family physicians are in underserved and rural areas already, and there's a real need for rural practicing primary care physicians, general peds, general internal medicine. But as you'll see that in my workforce slides here, the real need is comprehensive family physicians. And again, I'm revealing my bias there. Ashley, next slide. Now, this shows a geographic distribution of primary care physicians, nurse practitioners, and PAs. And one thing it may not reveal so well here, but it really shows that family physicians somewhat mirror our general population. If you look at the column completely on the right, you'll see that family physicians are currently in the large rural and small rural areas to a degree in serving those practices. I know in our state, one of the concerns we have is we need more people like you with an interest in rural family medicine to take my place when the time comes. In our state, the average or median age of the family physicians in our state in rural practice are about 53 years of age. So we know in the next 10 years there'll be starting to be a turnover, and there's a real need in rural. But I think the point of the slide is family physicians in rural practices kind of mirror the general population. And we meet most of the needs of rural practice, but we need more rural practicing, primary care. Next slide, Ashley. So I'm going to focus a little bit on the scope of practice, and later when you hear my talk about a day in the life, I'll talk about specifics on that. Ashley, go to the next slide. This is actually, that picture is a picture of me in various things, but this is some of the services you provide in rural practice. And as a side, I'm going to tell you, as you look at healthcare systems and all the changes that are occurring, which sometimes I think as a student or resident are just settling, but I will tell you this, is your value to healthcare systems as you become comprehensive and have a full set of skills cognitively, procedurally, et cetera, makes you very valuable. And I would even go as far to say the more skill set you have, the more valuable you are. Now, I'm not here to say you're going to deliver babies in Boston, but you might. You'll be trained to do that. It might be uncomplicated, but if you came and joined my practice, I certainly want you to deliver babies right next alongside of me and serve the communities we are in. As you look through the list there, you can see it's pretty comprehensive. You're not stuck. No day is boring. The variety and challenges you see every day are there, and I'll let you read the slide. Ashley, go to the next slide. Now, these are some of the specific procedures. Now, I'm a rural practicing family physician and a former assistant director of residency, and we really trained our residents in all of these various services. So the full set of services you'll be trained in knowing or even exposed if you do a rural rotation like Jenna may be in I guess, southeast Pennsylvania as I'm talking here, is the challenges that come before you. You have to send people distances to get procedures done, and so many of the procedures you're trained in residency, and that scope is quite easy to practice in rural areas. You're encouraged to do it. It saves time and effort for the patients, and we often say in family medicine what gives us such value, and I think if you read some of the population health, is that broad set of skills and comprehensiveness we bring to the table makes us a valuable asset, and I'd go far to say that the foundation of healthcare delivery in our country. So there's a list for you, and I looked over all these. I do all of them. I do, in fact, I used to train my residents in ultrasound imaging. I just do OB ultrasound imaging. I also do colonoscopy, colposcopy, all the listed procedures there. And I can tell you my patients are very glad I do. They don't have to travel distances after preps, et cetera. And what you'll find, because you have such good relationships with your rural community, is many times they'll push you. I had a lady a week ago who needs a new aortic valve. And she said, well, Dr. Wergin, will you put my new heart valve in? I said, well, valvular heart disease is a little bit over what I do here. But I know a good person, Dr. Raines, and he'll do it, and I'll be right there with you when we get through it. So your patients have great confidence in you, and they really appreciate the full set of services that you can provide. Next slide. Talking about your career, how it might impact you now and in the future. So next slide. You know, the variety you see in family medicine makes it challenging but exciting. You're never going to be bored. It prepares you for really any setting of work, and I will say that emphatically. So if after a few years you want to move to an urban area and they say, well, what kind of doctor are you, Dr. Wergin? And I'd say full service, and that it makes you very attractive to them. Your learning curve is not steep at all. The set of cares, the long-term relationships, the communities you live in make, almost by default, make you a community leader. I'm the chair of our Milford Public School Foundation Board. I'm very involved with Kiwanis and other things in the community. I'm the high school football team coach and Shrine Bowl All-Star Game sideline physician. So you're really engaged with the community. So, and that gives you great flexibility even if you choose at some point to move. That skill set you have is very attractive. Next slide. So team-based care in a rural community, and this is an important point and fits right in with one of the focuses we're going to have in just 2 weeks when we launch our Family Medicine for America Health Project, which is a $22 million project to tell the public policymakers what family physician and a primary care physician is. But next slide, and we'll talk a little bit about team-based care. There are a variety of ways you'll entertain. In my state, we have a rural accountable care organization that's made up of just rural family physicians. And actually, if you look nationally at the pioneer ACOs, many of the ACOs that were most successful were primary care driven. And again, the comprehensive skill set you bring to an ACO and a value-based payment system is very attractive. So patients aren't fragmenting their care all over with errors in care, better care, and services you can provide. It includes many times, I'm a director at nursing homes. Many of our rural providers are the nursing home directors. You cover the emergency room when you're on call. I cover about a county and a half in my town of 2,000 when I'm on call at my critical access hospital just 15 miles north of here. So you get very good. You can still feel connected through teleconferences and telemedicine, and that's an evolving science as well. Is you don't have to feel like you're on an island or whatever. And our group's made up, I should have been clear, I'm in a town of 2,000. My hospital is 15 miles north of me. It's a 20-bed critical access hospital, so we do full-service care there and cover the emergency room when we're on call. We all have each location, there's 3 locations, but many rural practices have physician mid-levels with them. You provide the leadership with them, and you really use your nurses, you use everybody in your clinic to provide the best care possible for the public and the community you serve. And that's an important skill you'll learn in training, leadership skills and how to lead a team and how to keep the care part of a team-based care but physician-led. Next slide. Leadership in the community. I kind of touched on this talking before, is you're a big part of the community and an important part of the community serving their healthcare needs, but even more than that, in the school systems, on the athletic teams, as part of the government. And literally you're a big fish in a small pond, so to speak. And so if you want to focus on exercise and childhood obesity, it's very easy to do it in your community and raise the population health, community health in your community, because people look to you as the expert and look for you for leadership and advice on how to get healthy if they're not and how to stay healthy if they are. Next slide. This is a picture of me in my administrative roles as I was elected president-elect a year ago now, and as I said, I'm making this transition. I'll be president of an organization that's 117,000 members roughly right now, $105 million budget, and I practice in a town of 2,000 people and in a county that's 17.5. So I think the one thing that struck a note as I presented my skill set to the members of our academy and the Congress of Delegates was that I know family medicine. And the one thing about rural family medicine is you know the full scope of it and understand it very well. Next slide. So what can you do now? If you're a student toying with the idea of rural practice, even family medicine in general, next slide. This slide reminds me of where healthcare takes place. And this is an evidence-based slide that talks about where you're trained as a med student. You might notice the little red box way in the corner. Less than 1% of all patients are hospitalized in an academic medical center. And most of the care that our public gets are in my clinic as an outpatient and serving the needs of those. And that's what brings value to the system. And we create access. We don't deny people care. They're your neighbors. If you need hospitalization, you often use your home hospitalization. You also are very familiar with the community resources, and you'll often use those as well. So I think the point of this slide is often you feel like you get exposed to family medicine and maybe rural medicine, but remember, as you walk around Jefferson or University of Nebraska Medical Center or any of the academic centers, it's an important thing to learn, but the full spectrum of what you're going to be doing when you leave that, they're less than 1% of the population that is delivered care in our country. Next slide. So what are the advantages of the students to look into careers? And one of the focuses I've had as a president-elect and I'm working on is to remove those barriers to becoming a family physician. And in the era of transparency, I have to tell you all that my son is a senior medical student at the University of Nebraska and going to go into family medicine. And so I understand some of those barriers, a la debt. And I know they say the average debt load is $170,000, and I think that's really understating it. I think most students are $200,000 in debt. You won't be poor as a family physician, but we want to make it easy to make that choice, to have you paid better as a family physician. That's one of our focuses, but also to get your debt relieved. If you're moving to an area that's underserved, et cetera, many times you'll get debt relief by moving in those areas. The set of skills you have, if you look at the income potential, you know, when you look at the data, it's a mishmash of averages. But rural family physicians in general, because of the scope of skills we provide, usually have a higher income. And you could build your resume for moving on if you choose to do it. I always tell students, I think it's rewarding being a rural family physician because you can choose your future. And you can stay in your community. I have 8 partners in Seward, Nebraska, and another partner in Utica, Nebraska, and we all have kind of different forms of practice and how they do it. Several of my partners have young children say, we don't want to do call. So we step up and the rest of us take call, and that's it. And they chose that, and it's understandable, and it's not a big burden in our practice. So each location is a little different, but what I would tell you, even in urban areas, you get to choose your future, especially with the broad set of skills you have as a family physician, particularly as a rural family physician. Next slide. The other way is how, you know, students, often they ask me, well, how do you find out what it's like to be a rural family physician? And I'll give you a little story about that. I had a student from Johns Hopkins call me and say, my grandparents live south of me in Saline County, where my practice is, but I want to do a rural family practice rotation with you. My grandparents go to you, speak highly of you, and I said, sure. But there were some little barriers, even with Johns Hopkins, in that they don't have a department of family medicine at Johns Hopkins, and we'd like them to. But so we kind of designed a curriculum, submitted it, they accepted it, and he worked with me for a month. And at the end of the month, he said, wow, I had no idea the variety and the things you do. And as a follow-up to him, he stayed in contact with me by email, and he matched in family medicine, one of the few people in his class. But exposure is I can tell you what it's like, but setting up a sub-internship or a rotation in a rural area, that's when you'll get the real feel of what it's like to be a family physician and the broad scope of things you do. There's sometimes rural practice or family medicine interest groups on your campuses. Going to conferences like the National Conference of Student Residents often have things on mission work or global health, which, oh, by the way, as a family physician, you're much in demand there because you have that broad set of skills going to a very unserved remote area and rural areas that often haven't had access, but your skills as a family physician are very appealing. Some of the programs also have built-in debt relief within them. And one thing that holds true is you tend to practice where you train. I'll just point that out. So as you get out, if you say, gee, I want to go to Maine, I want to go to Nebraska to a program there, often that's where you end up practicing. So we are working on reducing those barriers to choosing a rewarding career in family medicine. And I think we made big headway. I can tell you when we go to Capitol Hill, the senators all get it. Every state, when you talk to the senators from New York, they say, well, northern New York is very rural, much like Nebraska, but a few more trees and hills, but beautiful area. Next slide. And we have questions at the end here, but before we do that, what I did, and kind of back a ways, this is a slide that as I ran for office, I took pictures with my patients, and each one of these slides that you'll see in the left lower quadrant, I practice in a Mennonite community, and the girls there, the mother and two daughters, one thing about my Mennonite patients, they don't wear slacks. They're always in those straight dresses. They're wonderful patients. The patients that I'm standing in front over are people I grew up with. The patients directly above me that in bed with a baby, that baby's under 24 hours old. I delivered that baby the day before. The right-hand lower quadrant is me doing a circumcision actually on that little boy. So what I want to do is talk about what I do as a family physician. Now, I know being president of the academy is a bigger job than just in my small community, but it states who I am and what I am states a lot about what a family physician is. So I may be looking down off and on here, looking at my spot paper, I wrote this down. So I usually start each one of my days at the hospital, and I round on the patients who I've admitted or my partners on call have admitted. So on this particular day, I started my day. My first patient was a post-op C-section, which I do cesarean sections as well. It was a repeat C-section. This mom actually, this was her second child. She was doing great, incision good. She was an experienced mother and wanted to go home. I was trying to talk her into maybe spend another day because she had another child at home, but she was probably going to go home that evening. Her son over in the nursery, it seems like I've delivered a lot of boys lately, it was doing well. His color was good. He did not look jaundiced. Mom was A positive, not OAs, or you got to watch for bilirubinemia with them. The baby was actually doing pretty well with breastfeeding. We encouraged that. Had a lactation consultant in my little hospital, and I did do a circumcision on him then that day after discussing the pros and cons with the parents. My third patient was one of my, she was 73, chronic obstructive pulmonary disease, and came in. I've known her for some time, very short of breath in the room, more so than usual. She usually just uses oxygen at night, but had her oxygen on. I often get my patients to have oximeters so they can track their O2 saturation, and I did admit her. She'd been on antibiotics, steroids, and was doing much better, but not wanting to go home, but I felt she needed another day or two in a transition to oral medication. My next patient was a 35-year-old male who was admitted overnight who had a kidney stone and was vomiting. We had to admit him for pain control and hydration. I'd started him on Flomax, and we were straining his urine, hopefully to catch his stone. The next patient I had was a 71-year-old male who had diabetes mellitus, memory loss, and his blood cultures returned 2 for 2 positive for gram-negative sepsis. And he was actually my former Boy Scout master. I practiced in town I grew up in, but he was doing well. And I'm in a small hospital. I discussed with him we could transfer him up to a big hospital. He'd become afebrile. His white count was coming down. He was really clearing up nicely. So we chose to keep him there. He was going to need a prolonged course of antibiotics, which I could transition him to skilled. And his son, who's a friend of mine I graduated from high school with, we talked it over, and they felt very comfortable staying there, and I did too. He was feeling well, and that's one of the things you have to learn to deal with on an inpatient stay. The last patient I saw, I had a pretty big inpatient stay, was a 81-year-old person who I'd just seen the week before, but came in with left hemiplegia and aphasia, and was meeting with the family. They were dealing with that, but I thought he was beginning to improve, so I was encouraged by that. He lives on a farm west of Melford, so I already started social services. I didn't think he was going to be able to return home, but it's early in his course, but he was making some improvement. The next thing I do after I round off is do procedures. So I mentioned to you that I do OB ultrasound. So I had 2 of my OBs in to get their ultrasound. I like to do them between 17 and 20 weeks. The first patient was a woman who had had 2 previous kids. She was a G3P2, and I usually let them bring their kids in. And her 2 daughters wanted another sister, and as I was doing the ultrasound, which was good fluids, good fetal survey, her dates were quite accurate, but her daughters were a little disappointed in that she had a little boy, and it was pretty obvious on the ultrasound, so they had to deal with that disappointment. I didn't really say it out too loud to them because I think they still wanted a sister. It's too late though. They're going to have a little brother. The next patient I ultrasounded was a 17-week primip, and she was there with her husband, and everything checked out well, and she had a lot of questions and nervous, but it was real reassuring for her to see that baby in the organ survey, and it said everything looks fine, and she'll be following up then in about 3 weeks. My next patient, I mentioned to you that I do colonoscopy, was actually an 84-year-old woman who was my kindergarten teacher, Mrs. F. And Mrs. F had some bowel habit change and a little blood in the stool, but didn't want to go away to do her colonoscopy. So I said, well, we can start here. We'll start with that. So I was a little late getting in the room, and then my endoscopy nurses were quizzing her about embarrassing stories, I think, of me as a kindergartner. And I came in on kind of the end of her story before I started the colonoscopy. I couldn't give her enough Versed quickly to get her quiet, but so she was telling a story that she realized my kindergarten class was one she wasn't adequately prepared in teacher's college for all the duties that a kindergarten teacher needs to do. So the first day of class, one of our orientations, she took the little boys in the boys' restroom and showed them how to wash their hand after using the facilities. And then each little boy, there was only 8 of us in my class, we had them walk by the little stalls, and there was a long trough urinal. And she said those 8 little boys lined up there and looked up at her and said, hey, how's this work? And she realized she didn't have adequate training as a teacher to tell them how this worked. But she said, luckily, there was one little boy that stepped forward and said, I know how this works. And he undid his pants. And she said, in just a short while, there's a little amber arc of urine going over that long trough urinal. And she said, pretty soon, there were 8 little arcs of urine going over there, and these proud kindergarten boys who had learned how to pee in a urinal. And she said that little boy was Dr. Wergin. I always knew he was going to amount to something and be a leader someday, so I tell people it's all been downhill since then. Anyway, so I did do her colonoscopy. Luckily, she had some internal hemorrhoids, but not much else, so we got her on a bowel program. She was going to follow up with me in a couple of weeks. Then I drive the 15 miles to my office, and I'll just quickly go over these so there's times for questions at the end. My first patient was a 2-week-old well child check. It was a little girl. She also had 2 sisters with her. The parents often bring the other kids with her. Good color, was breastfeeding well, had already started to gain back some of the weight loss they get right after birth. And mom seemed comfortable in the care. She's an experienced mom. It's also an opportunity for me to kind of quiz the mom, and I'm very sensitive about postpartum depression, but when you see these people and their families and you know them, it's a little easier to pick up on that. The next patient was a 25-year-old male from the Vocational Technical College here in town. He had had 10 days of a sore throat that waxed and waned, had some low-grade fever, not a lot of cough, a lot of sinus drainage. He was a smoker. Due to the duration of his symptoms and the fever and stuff, I chose to treat him with an antibiotic, and of course, counseled him on quitting smoking. You never know when they're ready, so I always do that. The next patient, I tend to have some acutes worked into there, was a 15-year-old with a sore throat for just a couple of days, not a lot of fever, just a slight cough. I did do a strep stat on him that was negative, and we decided we were just going to watch and wait and treat symptomatically with throat lozenges, fluids, and rest on him. The next patient was a 63-year-old with dyspnea on exertion. He normally could mow his lawn and do things, and he just couldn't do it without taking breaks. He'd had a previous coronary artery bypass about 8 years ago. He's got diabetes and hypertension. He followed at the VA, which is about 50 miles away, so I often join up and deliver his care when I can there. He had a lot of rolls in the bases. I worried a little bit about heart failure. We did some labs, a chest x-ray, and he had a nodule that was new. I had an x-ray from 3 years prior in his right middle lobe. I had the radiologist review it. So I was trying to coordinate the care back to the VA, which you do a lot if people are outside your office. But he said, you know, Dr. Wergin, it's just so hard. Can you just do this? I said, sure. So we set him up for a CAT scan. He's going to get an echocardiogram. I gave him a little Lasix. He was already on an ACE drug, so we were going to follow him up in just a week or two to review the labs. I'm quite concerned that might be a malignancy. The next patient was a 67-year-old white male. The listed thing was face-to-face visit for diabetic shoes. They have to come in to get that. And his name was Ron, and he came in and I examined him, and his diabetes was good. But as I was filling out his form, I asked him, "What are you going to do with your shoes, Ron?" And this is actually going to be in my speech. And he said, "Well, I'm going to start a walking program and get in shape." And I was kind of put back. I've been talking about walking and exercise, and I said, "Well, what's your newfound motivation, Ron?" He said, "Well, I'm out of shape. I need to get back in shape. When I mow my lawn, I have to stop twice and take a break. I get short of breath, and I get heartburn. And I rest a little bit, and then I can mow a bit, but I take 2 breaks. I always did my lawn all at once." I said, "Well, Ron, maybe your first part of your walking program ought to be on a treadmill over at Seward Hospital close by." And we arranged to set him up for a treadmill. The follow-up of that, he ended up getting a heart cath later at a 95% LAD, which now I'm sure he's doing his walking program successfully in his new diabetic shoes. That shows the importance of relationships. If I'd have just filled out the form, he'd have went away with a 95% LAD. The next patient was a 29-year-old woman that I had an antidepressant with some postpartum depression. She was about 9 months out, doing very well, enjoying her family. I'm very sensitive about that because it's a time you should be happy and enjoying your kids. She was sleeping well, her appetite was good, enjoying her kids to the degree she could. She has 2 kids. So I felt comfortable that we were still on the right course and going to probably follow her up in another 3 or 4 months. The next one was a 9-month-old with fever, runny nose, and the mother had seen the thing on Ebola and enterovirus. Certain that her child had that. I examined the child. I felt it was a viral illness, but not enterovirus or certainly not Ebola. So I reassured her and said, "Let's do some symptomatic care, and you can always come back in and call my nurse, member team-based care, or my PA. If I'm not here, we can work that out." The next patient was a 1-year-old well-child visit who was doing quite well, eating well. They were going to get their next set of immunizations and a hemoglobin, which was good. Basically a normal well child care. Her height, weight was about 50th percentile on both. Mother and her interacted well. My next patient was a 67-year-old male with COPD, but we recently diagnosed him with a cholangiocarcinoma, so he's dealing with that. He had to have a stent placed in to get rid of his jaundice, and he's getting some chemo that's kind of working. He's on a high flow O2 at home, so he has some other barriers. So I'm kind of following more for his breathing and working with his oncologist. The next person was a 70-year-old who had a basal cell cancer on her right arm, and I had done a biopsy with unclear margins, so I was going to re-resect that area to ensure we got the whole thing, and I did a multi-layered closure with vertical mattress sutures. It's kind of a shame to remove her old scar. It really looked good, but we had to do that. The next person was a 12-year-old boy who fell off the slide. I think really his brother pushed him, because when I first saw him, it didn't need to be manipulated. We cast him. His brother looked pretty sheepish over in the corner, and we casted him. He came in, and we had x-rayed it through the fiberglass, and it was well aligned, healing pretty well. We're going to go about 2 more weeks and take it off and re-x-ray it. And then my last little patient was a 7-year-old. The mom noticed some crusty lesions at the corner of her mouth. She had impetigo, and we discussed some of the issues, so the other kids didn't get it, and treated her with a topical and an oral antibiotic. So that was my morning, from 2-week-olds to 80-year-olds practically, with all these diseases. A lot of variety. It's a lot of fun. Each patient enjoys and looks forward almost to their visit. The kids often do, and they appreciate you. And that's one of the rewards of being a rural family physician. Boy, you know your patients, they know you. And that relationship, Ron's a good example of his diabetic shoes that turned out to be a heart stent instead. So I thought I would just stop there and see if anyone had any questions of me or about rural practice. I'm interested in what you feel are the barriers to picking family medicine, and particularly rural family medicine. I will say there's a big need out there in just about every state. Even the states you feel are urban, there's a lot of rural primary care need, general pediatrics, general medicine as well. And we have a big focus on that, removing those barriers and helping make sure there's enough training slots to deliver the types of physicians our country needs, which is primary care. I'll stop there and see if there's any questions, Jenna or Ashley.
Yeah, and Dr. Wergin, this is Sam at the AAFP. We just typed in some instructions on how to submit questions. We asked the people to host using the chat function. We did have a couple come in during the call, so we can start with those. And then as you're answering them, we'll see if we get any more.
Okay.
So the first question is, how do you ensure work-life balance when you practice full-scope family medicine?
Well, that's where I go back to choosing your future. And I will say, as a rural family physician, there is scope creep as you're there. Your patients want you to take care of them. And the work-life balance in my group, I mentioned, I have 2 female partners who have children, and they chose, I don't want to do call. And we were willing to, they're very accomplished, good docs, and so they don't take calls. So what I would suggest is define it right up front with your expectations of what your work-life balance is. We also, in our group, in my group, we don't have that, but in the Steward office, they rotate each day. One of the doctors, or actually 2 of their doctors, go home about 3:30 or do family activities and all that. So I would say it's accomplishable even in a rural setting if you're joining a group of docs. It's a little bit harder if you're on your own, but between you and the PA, many times you can work out those work-life balances. And I'll go back to say, I've said this multiple times, you choose your future. If you're in an urban area, it's even easier to say, I want to do this much, I've got a family, I want to do that much, or whatever that is. What I would encourage you to do is don't sell yourself short. You'll be trained to do the full scope of family medicine, and that makes you attractive to rural or urban. But define it at the start.
Great, thank you. The
Thank you,
second
Tim.
question is, how do you keep updated on the newest clinical information and innovations?
That's a good question, and you can do it through electronic means. Our academy has a lot of that. This webinar is a good example, and we're moving over into electronic ways. I get a lot of my up-to-date information from going to conferences, and I'm biased. I go to the AAFP annual meeting. I go to my state annual meeting. The RAFTA speakers often are talking about changes or updating chronic disease management, acute disease management. I told you I do OB. I always look for that. I like dermatology, which can be challenging. We had a great derm talk just a week ago at our Nebraska Academy meeting. So either attending meetings directly or through webinars. And I still read. I get the American Family Physician. One of the advantages to being a student member, you get that in the mail, and they're nice review articles. So usually electronically or attending a meeting directly. The other thing I learn is from my partners. They go to a meeting, and 2 of my partners are doing dermoscopy and get me interested in doing that to look at moles that might be at high risk, and they went to a course to do that and are doing it right here in our rural county. So you can even learn new skills.
Great, thank you. Next question is, you seem to deliver a lot of babies. Most family physicians I speak to no longer do this because the liability has become so high that they cannot afford to or are not allowed to, even in rural areas. How have you maintained this part of your practice?
Well, there are a couple things. It was a focus of mine. I enjoy delivering babies, and as you can see, I'm a little bit older, and my practice has aged with me. I love seeing kids and watch them grow. And one thing I'll tell you, you feel part of their family. When they come in, they squeal and say, Dr. Wergin, and all that, so I enjoy it. In our state, there's a liability limit so it's easier to do OB. But even when I practiced in Colorado years ago, as I came out of residency, the cost was high, but I was trained and I was able to show my competency and still did it. But you're right, the questioner is right on, is that we've seen a decline in the number of family physicians doing OB, and to me, that's okay. You can tell I have a passion, I still enjoy it. Many of the people my age have kind of quit doing it, but I still enjoy the joy of delivering that baby and handing it to the mom and a dad that's beaming, slap me on the back, and thanks, doc, and then getting to see those kids grow up and go through school. That just makes me feel warm inside, drives me. But there are a lot of other opportunities too. So as you go through, that would be something. If you want to do that, it may limit some of the areas you choose to practice in, maybe even some states that they alluded to, if there's not liability reform. But it's a shame that you can't do that. Where I'm at, I told you, I do cesarean sections of that largely because when I have bad heart tones or things aren't going well, I can't really load them up in an ambulance and haul them 50 miles. So several of my partners help, and we do that, but we had extra training to do that. So you choose your future and what you want to do.
Great. On to the next one. Thanks for your presentation and well wishes to your ongoing leadership in overseeing the AAFP.
Great.
Have you had any experience with incorporating group patient visits with your medical team in a rural setting? For example, for non-acute care lifestyle modification education?
We do, and it's a team-based approach. I have not individually where I've participated in it. We're actually moving to that. Telemedicine's another area. I think there's a great future for rural practicing doctors. But we use it in some chronic disease management like diabetes. We have a diabetic focus group that usually starts with a speaker. There's a group treatment. Usually one of us go and talk, and sometimes there's an outside person to come in and give an update on insulin pumps or new trends in diabetes and stuff. So we've been doing it that way. Several of my friends in rural areas, again, have group visits they're usually somewhat disease-oriented, not so much preventative. Where I do my preventative type interventions, and to be honest with you, it's in the high school and grade schools. Each year I talk to all the kindergartners about healthy lifestyles, eating and exercise, and the teachers love me coming up there, and it's amazing how many times and the questions you get from kindergartners. I say, if you do that, you'll love it, but be prepared. It's you never know what they're going to ask you. And then as they get a little older, talking about things that pertain to their stage of life and stuff, and still emphasize obesity, exercise. As you get older, their choices in contraception or not, whatever those kind of choices you're going to make. So usually you team up well, especially rural. It's very easy. We also do tar wars, the PA and I do here, about smoking to the fourth graders.
All right. We're not seeing any other questions coming through. So, Dr. Wergin,
okay.
Do you have any last comments?
Well, first of all, I want to thank Jenna and the AMSA folks and all of you for letting me participate tonight. And you know, I gave you my practice style and that, but remember, as your president, I'd encourage you to become a student member, to go out and do an internship or sub-internship in a rural area to get a feel. If you have any interest in that, we'd love to have you out here in Nebraska or somewhere else. And even if you don't choose that, that's okay. We don't care. And the beauty of family medicine, I believe that the value of a family physician in what's coming, the future of family medicine, which I'll be doing at our annual meeting in just 2 short weeks, is it's bright, and you can choose your future. You decide what you want to do and how you want to formulate your practice. And I can speak from experience that you have a big impact on your community, and I hope me being here has helped my small community of 2,000 be a healthier community. Thank you again for allowing me to share my views with you tonight.
And thank you so much for joining us, Dr. Wergin. We really, over at AMSA, really appreciate all of your efforts with the AAFP, and really enjoyed having you speak to us tonight.
Great. If you come to the annual meeting, see me walking by, grab me and say, I heard you and I want to talk about rural medicine. But be ready. I'm very passionate. You might have to stand there a while.
I think we'd all be all right with that.
All right.
And for anyone still on the line, we just have some resources displayed now. We'll give you a couple minutes to take from that what you need. And then we have one more slide, and that will conclude the webinar.
That's great. I have a big focus on that repayment forgiveness part of that. We're working very hard on that from an academy standpoint.
And we definitely appreciate that as well.
Yes. You'll notice that article on the top is my ACO in rural Nebraska.